for joining me. I'm Hillary Knight, a dentist in New Buffalo, Michigan, and today's presentation is on children's airway health and oral care. I recently became interested in craniofacial development and am fascinated by how it connects to whole body health. And so to kind of give you a little picture, this is my friend here. Everywhere where you see the yellow, that's the maxilla bone. And you can see how it is actually, it makes up the floor of your orbit. It goes, it supports the sides of the nose here. So the whole nasal cavity, the entrance of it is all maxilla, and the floor of the nose is maxilla. And then of course, as we know it, the roof of the mouth is the maxilla too, and that's where the teeth are housed. And it also comes out laterally to the sides here and supports the mid face, or what people would say is their cheekbone area. And so its development can impact a lot of different structures in the face and the airway. And so in that regard, it can impact a lot of different body systems as well. Okay, so my next photo is this healthy self, heal thyself. And this kind of sums up what we're all about, and what we're trying to do here is use our own genes, our own bodies, the way that they were designed to do. What we're talking about is just helping us see how we can do that. So what I'm going to share with you is the foundation for how you can help your child develop into a beautiful adult with straight teeth and healthy functioning airway.
Awesome.
All right, so the first thing we need to know, and I'm actually going to go ahead.
I'm an orthodontist.
Main thing we need to know is that we can change facial form, but it's difficult to do this. It can't be done using orthodontics alone. And orthodontics, when I say orthodontics, I mean moving the teeth. So I'm going to play a little video by Dr. Mew, and he will kind of explain his philosophy from an orthodontist standpoint.
So I come to this area from an orthodontic perspective, and in principle, why are teeth crooked? It was the big gap in my training. And to be honest, the orthodontic profession openly admits that they don't know why teeth are crooked. They can attribute a cause at about 5% of the population. And those are usually the syndromes, the traumas, the really obvious ones. It's not the average person. For your average person that goes to an orthodontist, they don't know what causes the problem. Now, the hard scientific evidence, well, interestingly, the quality papers in respected peer-reviewed journals seem to all strongly suggest that this is a disease of the environment. It's an acquired disease. None of our ancestors had crooked teeth. None of the other 5,400 species of mammals have crooked teeth, except possibly a few domesticated cats and dogs, which is what we would expect. And it's only through understanding the cause of a problem that we're ever going to be able to properly treat it, because medicine is about treating the causes of the problem. Now, one of the...
I kind of skipped a little bit forward ahead, so we'll play this next little snippet too.
It also concerns me that at the end of therapy, people are required to wear retainers indefinitely, forever, the rest of their life. Surely something must be very wrong with the treatment if it's unable to maintain a permanent correction. And the whole concept of holding teeth out of their balance zone permanently really worries me. Worries me that that will affect the actual life of the teeth.
Okay.
It also concerns.
So the foundation for all of what we're going to be talking about today And what you need to understand is that our faces actually change in response to muscle pull. So both in action and in resting postures. One cool x-ray that I wanted to share with you is this is a human skull. So this person was 28 years old, and on the back of their skull, they're actually developing this little bony protrusion, and it's from this forward head posture, the texting posture. And so people are starting to actually develop this bone from that repeated posture. So it can happen in multiple ways. That's just one interesting example there. All right. Other examples. The one on the bottom left here is a boy who at age 10 took home a pet gerbil and he kept it in his room. And he was actually allergic to the gerbil. So in order to breathe, since his nose was stuffed up all the time, he actually had to breathe through his mouth. So he was always with a relaxed posture of the teeth. And you can even see in this picture right here at age 17, even at rest, the lips are parted. But when you look at him from the profile, he doesn't look like he was on track with his development at all. Now, all of a sudden, it looks like his nose is becoming a lot more prominent and the chin is quite retruded. And you'll see later that this is a response to those muscles kind of making the face sag low. Another interesting example, this is a set of twins. They were 12 when they started treatment. You can see their front face and the profile is pretty similar in both of the girls, but they went through two different types of orthodontic treatment. So the girl on the left went through a type of orthodontic treatment that's still fairly common in the US today, where she had her bicuspids extracted to make room for the teeth and then orthodontically aligned. The girl on the right went through a different type of treatment through something similar to what we're talking about with the growth appliance to grow and expand her maxilla to accommodate all the crooked teeth. And you can see that her face is quite different from her sister's. It's a little wider, the cheekbones are more lifted. And I mean, they both have gorgeous teeth. The smile is nice, but the face shape is completely different in the two girls. So what are the environmental factors that can change your face? Number one is diet. Diet can cause the face to change form. This is a picture from Dr. Weston Price. He was an anthropologist who traveled to many different remote places and studied different cultures. And what he found very interestingly was that the cultures that didn't have westernized foods or industrialized foods had nice straight teeth. I mean, some of them had wear, you can see, but they're all in well alignment. In the first generation after westernized food was introduced, or softer foods, you can already start to see there's a lot more crowding and crooked teeth. So for us in the US, early diet still plays a role. We'll talk a little bit about bottles and soft purees. So craniofacial development has the most rapid growth between ages 0 to 4. And this is a cool little picture. It shows you kind of the outline of how a skull develops. 2 years old is in the center here, and then out to age 17. In this mid-face area, you can see that the face grows forward and almost lifts a little bit in a healthy growing position. So that's what we would like to see in healthy craniofacial growth. So where diet comes into play, during those first 4 years, it's really critical to help develop the mid-face based on what the child is eating. So breastfeeding, we know, helps to develop a healthy face structure. The way the tongue has to work to get the milk out, it's pushing against the roof of the mouth, and it's pushing in an upward and forward direction. And so the upper jaw is very supported, and it's allowed to grow forward and out. And then once the baby starts eating solid foods, now we always give them purees or pouches or, you know, baby food on a spoon. And I, you know, I'm guilty of that too. I didn't know any better. It's our culture. But the problem with that is that the tongue begins to get lazy. And so it doesn't do as much action against the roof of the mouth as it would if the child was trying to eat a natural you know, maybe a slightly softened carrot or something like that. And so we see crowding and malocclusion in our society widespread. I mean, it's almost every child that we see. It's very actually rare to see a well-developed arch because it's not our culture with the diet. And sometimes, you know, with the nursing, it's just not practical. So if you are going to be someone that uses a bottle for either pumping or using formula, you want to try to get a nipple that's more realistic to what the breast would be. So the baby actually has to work at trying to extract the milk. Instead of you know, just a regular shaped bottle that basically they, you know, don't have to work at all to get it out. Okay, so early diet can play a role, and you know, we kind of say, okay, well, that's part of our lifestyle, but what else? The other big thing is poor tongue posture and mouth breathing over time. So this is kind of just a little schematic, and you can see some of these things that I've listed here in the drawing. So the top is somebody that has good tongue posture and they have their lips together at rest. And the bottom would be somebody who has that posture where they're actually breathing through their mouth and not through their nose, whether it's because of allergies or that's just a posture that they adopted. And so you can see that the face starts to have less definition in the cheekbones. It's a more narrow, more long-faced appearance. And if you look at the profile, sometimes it makes the nose look bigger. And it's kind of an optical illusion. The nose is the nose, but without a good, strong chin, it makes it look like it's sticking out from the face. And the face sometimes gets this more of a convex shape to it as well. And you'll see in the next video how that shape of the jaw can then impact the airway, which is the most important thing. So that answers, that's my leading question. What impact does the face shape change have on the body? And it affects the airway. So I'm going to let Dr. Mew explain this as well.
What useful? If the tongue is on the roof of the mouth at rest, and there's a strong biting force between the teeth, then the face tends to grow forwards under tight control. And yet, if the tongue is hanging low in the mouth, where you're resting with your mouth open, and you have weak muscle tone, then the face tends to lengthen, dropping down. And certain adjustments are then made to protect the airway. The facial form seems to have dropped down and back. It seems to have downswung. Here we have an image of an ancient man set against an image of a good grower. And you see how the whole facial form seems to have dropped down and back. And of course, this is carrying the tongue down back towards the airway. This is what we refer to as a downswinging facial form. You see this young girl, she is a good example of how, as she has grown, her face has downswung. As this has occurred, her face has lengthened, and since she only has so much face, it has also got narrower and it's got shallower. So within the cross-section area, there is less space for the tongue, her teeth, and the airway. So she'll have crooked teeth, but also she's got a restricted airway. And there's certain compensations that we can make to correct this. The first compensation is moving the head and neck, usually extending the head to open the airway. And the second is changes in the position of the tongue and the jaw. So we've termed this downswinging facial form as craniofacial dystrophy. This is the first time someone's tried to put a name to the pathological process underlying crooked teeth. Now, it seems that a face that's not the right shape isn't going to work as effectively as if it had the correct architecture. And there's a number of different problems that seem to be occurring as a result of this change in facial form. Things like blocked noses. If your face is narrower, you're more likely to have a blocked nose. Sleep apnea and snoring. Probably the biggest symptom is not crooked teeth. It's the effect on the airway. And how, as the face downswings, as it melts down and back, the tongue is being carried closer and closer to the airway, closer and closer to the hyoid bone. It seems that one of the most statistically significant measurements is insertion of the tongue and the back of the pharyngeal wall. And as this reduces, the chance of sleep apnea increases. So the more downswung you are, the more you're likely to have sleep apnea. And this is very well demonstrated in multiple studies. And of course, if you're snoring today, you're likely to have sleep apnea tomorrow. And the raising concern is the effect of sleep apnea on the IQ and social development of children.
Okay, so what are the symptoms that a child may experience due to sleep disrupted breathing caused by a small jaw? There are many things that can be affected by not being able to breathe properly at night. This list is kind of the biggies and what we really look for. I'm going to play another short video here in just a moment about ADD and ADHD and the tie there, and I think Dr. Moralia will explain it very well. But that's a common thing that we see, that some kids are getting misdiagnosed because they're having the same types of inability to focus or concentrate in school because they didn't have a good night's rest as those kids that maybe truly do have ADD or ADHD. And in our country, there's a lot of kids on medications right now that probably don't need to be, and this just needs to be better understood. Bedwetting is one too, and Dr. Moralia will also explain the link there between nighttime breathing. But one common thing to look for is mouth breathing and snoring, and those are pretty obvious. Some patients will experience restless sleep. You may see that a child may not be growing to their full potential that you would expect. Some other nighttime things are nightmares. And sometimes it can be sleepwalking too, or talking. If you don't get a good night's rest and you're not able to get that reparative, restorative sleep that you should be getting when you get into your deep sleep cycles, you can also have a harder time controlling your emotions and your mood. And so some children will present with irritability or anger. They might have difficulty calming down, morning headaches. He touched a little bit on, if the face is swinging down, that the nasal passage doesn't have as much opening anymore. And so now you might be more prone to getting chronic allergies or asthma, which of course then makes you want to mouth breathe more. And so that's kind of a vicious cycle. Back to your mental acuity, a lot of patients experience depression or anxiety because they're not getting their full sleep at night. You can see a lot of wear on the teeth with teeth grinding too. And a lot of children with sleep disrupted breathing also have swollen adenoids or tonsils, because if you think about it, if you're breathing through your mouth, the tonsils are what's purifying your air. It's no longer going through your nasal passage where it's designed to go and being purified there, but now the tonsils and adenoids are having to do it all, and so they swell. Some patients will display aggressive behavior. Daytime drowsiness is a common thing. You get home from school and you want to take a nap. Well, you should have a little bit more energy than that if you had a full night's sleep. And so that can be a sign. It can be hard for kids to relate to other peers when they're not feeling like themselves, or they're not feeling fully well and fully aware. And then the last thing too, frequently waking up at night. And that relates back to that sleep cycle. And I should have put a picture of that in here, but throughout the night, we all go through about 4 or so cycles. So, you start in the light sleep and then you get down to the REM and then to the deep sleep. And the deep sleep's really where all of the mental health repair comes and makes you feel refreshed in the morning. Well, if your airway is starting to get occluded, you're actually going to be arousing yourself out of that deep sleep cycle multiple times a night. And so you don't get into that deep, deep sleep where, if somebody walked in your room, you wouldn't even know you're in such a deep sleep. Instead, you're staying more in the shallow sleep cycle. And so it can be really easy to be woken up by anything. And so that can be a sign too. So this is Dr. Moralia, and I would like for him to explain the connection between ADD and ADHD. There's a very large study that has shown the link because both conditions, sleep apnea and ADHD, can result in hyperactivity, attention problems, and behavioral or mood disorders. And the really scary thing about this is that if a child really does have sleep apnea or is having problems breathing, but instead we misdiagnose it as ADHD and put them on medication, sure, they might be a little more calm in school and they may seem like they're more focused, but that's just the medication kind of covering up what's really going on. And so they may still have memory problems. They may still not learn as well in school, and they may still feel those other, aggression or depression or anxiety. So I'm going to let Dr. Moralia give his explanation here.
Take a child, alter their quality of breathing and sleeping. And the real big issue now is how will they be during the day? So now you take a child who's 5, 6, 7, 8, it doesn't matter. Their issue has begun years ago. So it's not like you had 1 or 2 bad nights of sleep. You've had a poor quality of sleeping and breathing for years. And the parents have been struggling with so many different issues, and not the least of which is the ADD, ADHD discussion. Because the child who doesn't get a proper night's sleep with a good quality of breathing throughout the entire night is going to wake up and be unrested. And when you get a child who's had a poor quality night's sleep, poor breathing all night long, and you make that happen for years, you know what you've got? A 6, 7, or 8-year-old that's going to go to school and have trouble learning, have trouble sitting still, have trouble behaving, have trouble cooperating, basically have trouble fitting in to what is supposed to be a quiet, peaceful, and learning environment. And it's not long after that where the phone call comes to the parent. And when the phone call comes to the parent from the school, what happens is, we have little Jimmy here and he's a little bit disruptive and we really want you to have him evaluated for ADD and ADHD. They're going to be diagnosed with ADD and ADHD, and our solutions are pharmaceutical. If we are given a pharmaceutical, it's usually in the form of some sort of a stimulant. And what that does to the child is it kind of pushes them over the edge and it brings them back to calm. So you basically take an excited or hyperactive child, you stimulate them more, and you bring them back to so-called calm. But it doesn't make a better learning child. You're not going to have a child who's able to learn as well. So now you might have the child sitting still in class because they might be a little more numb or relaxed or calm, but it doesn't necessarily make them a better learner. We have the so-called ADD, ADHD diagnosis. We're talking about hyperactivity. We're talking about all of the things about behavior and development that land in this category. And the interesting thing about research is, and there is current, ongoing, and past research that shows children who are sleep deprived produce the same exact symptoms as kids who are diagnosed with ADD and ADHD. In fact, there's a nice study that showed children who were diagnosed with ADD and ADHD were mixed with children who were sleep deprived. And in that group of kids, when they tried to analyze them and look at their symptoms and diagnose them, they couldn't tell them apart. And if you have a group of kids and you can't tell apart who's an ADD child and who's a sleep-deprived child, it's no surprise that maybe the ADD and ADHD has a cause. And maybe that cause has to do with the quality of the breathing and the sleeping overnight. And there's a lot of research out there. And one of the pioneers here is Dr. Steven Sheldon out of Laurie Children's Hospital in Chicago. And he does a wonderful job of researching, and over the decades, he's come to a conclusion, and I've seen him speak, and it's not soon after he jumps on stage and he makes a statement that ADHD and ADD do not exist. They are an outcome of a sleep disorder breathing. They're an outcome of a poor quality of sleep. It's all about the quality of sleep. Another researcher who's produced beautiful research on the same topic is Dr. Karen Bonik out of Einstein at Yeshiva University. Dr. Karen Bonik has the largest study to date. 11,000 children were watched over 7 years. And they were divided into 2 groups, sleep disorder breathing children and children who do not have sleep disorder breathing issues. The children in the sleep disorder breathing group, over their 7 years, her study showed that they were 50% more likely to be diagnosed with an ADD or ADHD diagnosis and treated with medication. 50% is a coin toss for a child to be diagnosed and treated with a medication. Also in her group, they were doing testing. They were doing IQ or intelligence testing along those 7 years. And the children with the sleep disorder breathing, their intelligence testing, their IQ scores were dropping over those 7 years. And that's really not the way it works when you're growing and forming. The formative growing years for a child, when they're sleeping and breathing well, your IQ raises to a certain point and then you kind of plateau. We don't see IQs diminishing amongst children.
Okay, and one other very common thing that we see is bedwetting, and that can be related again to the airway and how it functions at nighttime.
Another thing that might happen is bedwetting. Bedwetting is a little more common than people are aware because it's also a best kept secret. Not many people are running around and advertising that their child is bedwetting at the age of 5, 6, 7, 10, 14 years old. But bedwetting does have a relationship to how we're breathing and our quality of sleep. And some of the causes for bedwetting relate to the way oxygen is exchanged in our body. And the way I'll describe it is this. If we're breathing through our mouth, that air coming into the lung isn't really filtered, warmed, or humidified appropriately, and the body can't exchange it appropriately. So a little less oxygen goes to the brain. Now, the brain is a very sensitive organ. When the brain recognizes little changes in oxygen, it goes to work immediately. Because once the brain starts to recognize a little less oxygen, it doesn't know if we're being choked to death, a very serious condition, or if there's an imbalance in how we're breathing at night. But it does start to trigger a little bit of the fight or flight response. And a little bit of the fight or flight response means the brain's going to look at the body and say, all right, if we've got a little bit of an oxygen issue going on, I'm going to pull oxygen from something that it picks to be unnecessary right now and maybe deliver it somewhere that might be more important, planning on the rare occurrence as if the oxygen was going to stop. So if the brain's recognizing a little less oxygen, all of a sudden it's pulled from the urinary tract. If the body pulls a little oxygenation from the urinary tract, it might void. So we might wet the bed.
Okay, so what are the visual or clinical signs that your child may have poor maxillary development? And these are the common things that we see and what we, used to say, okay, well, you're going to need braces for, but what I would propose we have a better solution for now. So the first thing is lack of space between primary teeth. So you can see in this patient right here, they're probably about 6 years old. So they're starting to get their lower central incisors in. And there's not enough room, there's crowding already. And so they've come in lingualized or not right in line with these two primary teeth because there's not enough space. You can imagine if the width of these two teeth was to fit right in here, they don't fit, it doesn't work. And so that's where they start to erupt in a position that's not normal. So I often have parents ask me, well, I see their adult teeth coming in, but the baby tooth's not loose, what do I do? Well, that's a sure sign that the arch isn't developing to its full potential because otherwise nature would have programmed those new adult teeth to come in right underneath the baby teeth, and that causes resorption of the baby teeth roots, loosens up the baby teeth, they fall out, they exfoliate normally, and life goes on. So in this situation, that's where I usually have to get involved and get those baby teeth out because there's just not enough room for the adult teeth to come into that correct spot. Here's just another, severe case of crowding. This premolar didn't even have enough room to erupt in the palate or in the arch form. It's all the way over onto the palate. Some mild crowding in the front here too. Well, I guess more than mild, but, so for this patient, again, it's simple to look and say that their arch has not developed enough to accommodate all of the teeth that their body was programmed to have. Other signs, dental signs, are underbite, so where the lower jaw comes forward, or overbite, where the upper jaw is more forward than the lower teeth. Or this scenario where you see more gum display above the upper front teeth. Sometimes we call it a gummy smile. All of these, again, are signs that the jaws aren't developing to their full potential. So some things that you can look for is an open mouth resting position. So look for your child at times when they're just relaxed, maybe reading a book or watching TV, and see where the lips are. So in this child, you can see the lips are parted and she's breathing through her mouth. And it's something that you may have never noticed before. And once you start looking, if you find it, it's a big clue. The other thing you might start to see is more of a longer facial profile and maybe even dark circles under the eyes. This is because the dark circles is because, if you can imagine that this bone hasn't grown forward as much and it's kind of sunken down or back, there's a lot of blood vessels here that are, they're pooling and they're not allowed to drain properly. So all of a sudden you get that kind of dark appearance under the eyes. Don't look at mine. The other thing that if you're a physician looking at this presentation that you might want to check for in your patients is the tonsil score. So we talked about how if you're mouth breathing, your tonsils are doing all of the air purification where the nasal passage should have been doing. And so the tonsils will start to swell. So, you know, we grade the tonsils when we do our patient exams here at the office. And so we can kind of see that. Just something interesting to note, it used to be very popular for children who had large tonsils or recurrent allergies or ear infections or things like that to have the tonsils actually removed. And the problem was they grew back, you know, and so it was kind of like a, well, why, you know, we're going to have this surgical removal and then, you know, it's going to be back again. And the reason that they reoccur is because the problem wasn't corrected. So sure, you can remove a tonsil, but or minimize it, but it can grow back if you're still mouth breathing and still irritating that tissue. One thing, if you're a parent of a younger child, that I would love for you to look at, and I would hope that other physicians are looking at in infants and newborns, is lip ties and tongue ties. And the reason that you want to look at that is because if the tongue doesn't have the mobility to move as well as it should, the child's not going to be able to nurse properly, which is the first way that the jaw starts to develop correctly. This one is a lip tie, so you can see that frenum is inserting at the height of the gum tissue there. Here's an anterior tongue tie that's a little more obvious. You can see the frenum pretty distinctly. And this one I would say is a grade 1, so it's coming right from the tip of the tongue. And the baby's not able to elevate the front of the tongue. This is a posterior tongue tie. It's a little more difficult to identify, and so a lot of these go missing. So if you do feel like your child has one, seek out a professional who can confirm that for you. But the thing to look for here is that, you know, the sides of the tongue are elevating, but he can't get the base of the tongue to come up. And so you start to see this little like heart shape of the tongue. So that can affect breastfeeding too. So you may be asking at this point, how can I help my child to have a healthy airway, straight teeth, and a beautiful face? Number 1 is to practice the proper oral posture and nasal breathing always, and that's key. Our faces were designed to have the tongue up at the roof of the mouth, right up here on the palate, and our noses were designed to filter and purify the air coming in. So how do you do this? I'll teach you the technique. Everybody should be doing this, whether it's during the day and you're just, you know, at rest, and especially at night before you go to bed. So if you say the sound N, the place where your tongue hits right behind your front teeth is where the tip of the tongue should be. So not really pressing against the teeth, but just on the palate right behind them. And then if you took a swallow, after saying the N sound, the tongue should elevate and flatten against the roof of your mouth, and it should kind of spread out and cover that whole palate space. Now, if you have a narrow arch form, you might feel like your tongue is spilling over the sides of the teeth, or that you can't really get your tongue all the way up against the roof of your mouth. And again, that's a sign that the arch isn't developed to its full potential. And so then, of course, you get your tongue into the right spot and breathe through your nose. So if you're somebody that has a lot of allergies, you may have trouble breathing through your nose. I would suggest doing what you can to make sure that nose is patent, especially before you lay down to rest at night. So you can use saline. Another thing that's great for the winter months is put a dehumidifier in the room. Make it as comfortable as you can to actually achieve nasal breathing. And then in function, you also want to make sure that you're having a correct swallow pattern. So a lot of us have a swallow that we've never considered before. I know I never did until I started learning about this. But a lot of us swallow with our facial muscles. So, you know, you'll chew and you'll see somebody purse their lips together, or they'll kind of squeeze the buccinators, the cheek muscles. You shouldn't have to recruit any facial muscles for a good swallow. It should be passive. It should be elevating the front of the tongue first, and then the back of the tongue follows, and it pushes the bolus of food down the throat. So this is just a short little video that shows a kind of a diagram of what a good swallow should look like.
Swallowing, or deglutition, is the process by which food passes from the mouth through the pharynx.
So this is the tongue right
as
here.
simple as it might seem to healthy people, swallowing is actually a very complex action that requires an extremely precise coordination.
So you could see that, you know, the tip of the tongue came up first, and then the rest of the tongue pressed up against the palate and finally swallowed. So see if you're doing that. Practice that at home. Okay, so let's say, you know, you do see some signs that either the growth hasn't occurred in the proper amount for your child, or maybe they are having some symptoms of sleep apnea. What can you do about it? And there are some simple things that we can do to help guide that growth. And so the first thing is a guide appliance. The ones that are on the upper right here are types that we use for younger children. So, you know, that first picture that I showed you, you know, most of the growth happens about 70% complete by age 4, but growth does continue up till age 12. So anywhere, you know, depending on how much crowding there is, anywhere up until age 12, we can use a guide system like this. And that would be something that the child would wear to bed, helps to train them of where to put the tongue, helps to open the airway, and also helps them to encourage their lips to have a nice seal and breathe through the nose. And there's little indentations in these guides too that actually help to move the teeth into the proper shape and form. If your child is a little bit more grown, age 10 or over, or there's more severe crowding, we can use a different type of appliance. So this is the Vivos Dna Appliance. It's got these little, they call them 3D axial springs, and that's where the magic happens. These springs are designed to touch very lightly the back of the front teeth, and it sends the body the signal, like the tongue would have done during development, to have that whole maxilla grow forward and be lifted. So it's not just about moving teeth. In fact, these appliances don't really move teeth at all. There's no pressure or force on the teeth. It's very passive. It's all in the stimulation of this bone. And so this is a type of what we call epigenetic orthodontics. So it's focusing on the development of the maxilla rather than just trying to move teeth around within the bone that you've got. And how it works is it actually activates or kickstarts your genes. It activates the epigenome, which is just the area that turns on or off certain genes. And so that can be affected by the environment. In our case, it's affected by the muscles. So with these removable appliances, there's nothing bonded to the teeth. There's no surgery. They are meant to be worn. The guides are meant to be worn overnight and for a few hours during the day. And the DNA appliance is meant to be worn about 14 to 16 hours a day. So in theory, you know, you could take it out to go to school and then pop it back in when you go home, and no one would even know that you have one. You can speak in them, but it does take a little practice. I've had mine for about 3 months now. I'm not wearing it right now, but I've learned how to adapt so I don't sound as much like I have as much of a lisp. So, you know, it is possible to wear them to work, but if you're on the phone or giving Zoom presentations all the time, it's probably not something you want to wear for that. And in the end, this little bonus is that facial aesthetics are enhanced, and you don't need to extract any teeth to make room. We're not removing anything. We're using what God gave you, your own body, and we're just activating the genes that are already there to work to their full potential so that you can accommodate all of your teeth. Let me go back to this really quick. Some patients will still, you know, once the bone develops, the teeth really just come into alignment. They go right into the spot that they were programmed to go. There may be a little rotation or a little tipping that's not the best aesthetics. And so sometimes we still do use clear aligners or light orthodontics just to make those tiny little tweaks for aesthetics. But many patients don't need that at all. So the last little snippet I have, you know, I did call this an airway health and oral care presentation, but the oral hygiene for someone who's learned how to breathe through their nose is so much simpler. mouth breathing leads to a much higher incidence of cavities and periodontal disease. In fact, if I see a young child, 3 or 4 that has cavities, it's almost usually because, I'll see it in between the teeth where they contact, but it's almost usually because they're a mouth breather. The parent will be like, oh yeah, I did notice, they breathe through their mouth at night, or I see them during the day breathing through their mouth. So if you can learn how to breathe through your nose, makes life a lot easier. Of course, I always recommend eating a healthy diet, low in processed carbohydrates. So that includes sugars, but it also includes things like white breads or chips or pasta that will break down into simple sugars that the bacteria in your mouth can still use. And then of course, brushing twice a day with either a fluoride or a hydroxyapatite toothpaste. You've all heard of fluoride toothpaste before, but if you're looking for an alternative that would also be very healthy for your teeth, the hydroxyapatite toothpastes are becoming a lot more popular now. Hydroxyapatite is the molecule that is found in your enamel. It's just calcium and phosphate. And if you brush with this, it's going to replace the missing minerals, similar to what fluoride would do. So great alternative. This one's the Risewell brand. It's a cake batter toothpaste. My kids are big fans. And just a gentle reminder, I still do encourage parents to assist with the bedtime brushing routine until age 6. Children just really don't have as much dexterity or awareness of the different surfaces of the teeth. And so sometimes I'll see, spaces where it's just been completely missed for months because it's just not in the way that the child normally brushes. So still help with that and guide and coach, but encourage independence too. Doing a lot there. And then floss daily. So if you have a child that actually has space between all of their teeth, you don't really need to floss. You're going to brush and you're going to clean all the surfaces. So again, oral hygiene maintenance for a nasal breather for someone whose arches are developing properly is a lot simpler. But most of us do have contacts in the primary teeth. So if you have contacts, floss them. And then the last little tip is just to neutralize the pH of your mouth with water as much as you can. So if you have water with your meals or after your meals, what you're doing is not only washing away any food that can be still stuck to the teeth, but you're also taking that oral environment from a very acidic pH and raising it back up to a more neutral level. And a lot less damage can happen to the enamel in a neutral pH zone. So acid is really what causes that enamel to break down. And if you can neutralize it, you don't have to worry. Okay, so just to summarize, all of these things that you see on the tree, and some of these, apply more to adults too. And if you're interested in that, we will have an adult educational webinar coming up soon too. But all of these things can be brought on simply because there's not proper breathing, especially at nighttime. So that's the root of the problem. And Epigenetic Orthodontics can help fix that. Here's some books that I would suggest you check out if you're interested in learning more. This Baby-Led Weaning by Gil Rapley and Tracy Marquette is a great book resource for new parents and trying to figure out, okay, well, I want to try to, do this right from the beginning. What foods can I use? What's safe? That's a good book to look into there. JAWS summarizes basically my short little presentation, but tells it in a really enlightening way, and they give a lot of good examples, a lot of anthropology examples. So that's a fascinating read. Breath has been really popular just in the past couple of months. It's been in the New York Times bestseller, and James Nestor talks about how breathing through your nose and having the proper depth of breath and awareness of breath can help with so many body functions. So, we're promoting nasal breathing, and he kind of takes it to a whole new level there if you're interested in that. And then this book is really, really good. It's by Matthew Walker. He's got a couple of short and sweet YouTube videos, and we do have them pinned on our YouTube channel as well under the Craniofacial playlist. So go ahead and check that out if you'd like. But he just makes the science of sleep make sense. He talks about it in a way where you can really understand and relate. So that's another really good one. If you're interested in taking the next step, you have a child that could benefit, or you know someone else, please give our office a call. We start with a screening, and we'll go from there. Thank you so much for your time. If you have any questions, you can reach out to me. This is my email address, hilaryvknightdds@gmail.com, and I will try to get back to you in a timely manner. Thank you for your time, and that's all I have for today. Hope you guys have a great night. I appreciated spending the time with you.